Hello, and thank you for joining today's Clinical Omics webinar, The Promise and Challenge of Immuno-Oncology. I'm Chris Anderson, the Editor-in-Chief of Clinical Omics, and I will be moderating the Q&A session at the end. To receive an immunotherapy are showing the kinds of long-term durable response to treatment that could, for them, change our view of cancer as a terminal disease to one that is a chronic condition. Today, our immuno-oncology experts will walk us through a brief history of immuno-oncology and the mechanisms of leading to a broader discussion on the clinical use of immunotherapies, known and emerging biomarkers that help identify patients likely to benefit from immunotherapy, as well as future directions in this burgeoning field. Our discussion will be led by Cheryl Elkin, the Chief Scientific Officer at molecular decision support company, N of 1. At the end of today's presentation, we will conduct a question and answer session with our speakers. Questions can be submitted at any time. To do so, simply type your question in the panel at the left and hit submit. And now to the presentation. Take it away, Cheryl.
Hello, and welcome to a Clinical Omics webinar presented by N of 1. Today we are going to be talking about the promise and challenge of immuno-oncology. My name is Cheryl Elkin. I'm the Chief Scientific Officer at N of 1. N of 1 is a company that focuses on clinical interpretation of molecular diagnostics for cancer, and we focus on clinical molecular diagnostics both for targeted therapies and for immunotherapies. My own background, I have a PhD in molecular biology, and I studied at Harvard and MIT before joining N of 1 approximately 9 years ago. And now I would like to introduce our speakers for today. And first I'd introduce Dr. David Barbie. And Dr. Barbie, could you please introduce yourself?
Yeah, hi, thank you, Cheryl. I'm David Barbie. I'm an assistant professor at the Dana-Farber Cancer Institute. I'm in the Lowe Center for Thoracic Oncology, and my focus is treating patients with lung cancer as well as other types of thoracic malignancies. I also run my own laboratory. I'm a translational oncologist. I've had my laboratory since 2010, and my research focuses on targeting oncogenic KRAS. However, more recently, we've also become interested in immunotherapy, and we'll talk a little bit more about that later.
Thank you. Dr. Irva, could you please introduce yourself?
Hi, my name is Walter Irva. I'm currently the Director of Cancer Research at the Earl A. Childs Research Institute, part of Providence St. Joseph's Health in Portland, Oregon. I have a PhD in immunology at UCLA and spent 10 years training at the National Cancer Institute in the Biological Response Modifiers Program. I have a long-standing interest, more than 35 years, in immuno-oncology with a focus on translational clinical trials as well as patients with melanoma.
Thank you so much. We're very excited for the conversation today. Dr. Irva, I was wondering if you could give us sort of a brief history of immunology and immuno-oncology in cancer as you've seen it over your 35 years.
Well, I think most in the field of immuno-oncology today will say that it started with Coley and his toxins at the end of the 19th century. Lots of blind alleys since that because, as you might imagine, the state of the science at that time was rather dismal. And I think the history of immunotherapy is actually the history of immunology writ large. And there's a long-standing, interesting history of discoveries in immunology, many awarded Nobel Prizes for their work with this discovery of phagocytosis, tolerance, immunoglobulin genes, and gene rearrangements. T-cell receptor identification, the identification of the major histocompatibility complex, and the fact that it's MHC restriction that allows T-cells to recognize tumor cell, and most recently the Nobel Prize for discovery of dendritic cells to Ralph Steinman. With each of these discoveries, we've all gotten a little bit smarter about how the immune system works, and I guess it's no accident that over time, as our knowledge of how the immune system works has increased, that the efficacy of therapy has improved. For example, if in 1980 Time had interferon on the cover of its magazine as the next cancer cure, and we all know how ineffective interferon has been for most illnesses. But then just 33 years later, cancer immunotherapy is the breakthrough of the year on Science magazine, demonstrating an enormous amount of progress in those 3 decades. For me, the first major advance was the discovery of IL-2, which became effective therapy for renal cell cancer, approved by the FDA in 1992, and melanoma in 1998. After IL-2, there have been a lot of other cytokines tested. Pick whatever number you like. Add tumor necrosis factor. Not a lot of activity, but I think a lot of lessons learned over the years about how the immune system works and what kinds of side effects we might expect to see. I believe the current age began when in 1994, CTLA-4 was shown to be a negative regulator of the immune system, and focusing on that strategy of releasing the negative regulation led to a clinical trial in 2010 that showed improved survival in patients with melanoma, and the drug ipilimumab was approved in 2011. During the time CTLA-4 was being studied, another checkpoint was identified called PD-1, and it wasn't too long after ipilimumab was approved that PD-1 blockade was identified as effective therapy and was approved in 2014. And not long after, the combination was shown to be effective and approved for melanoma in 2015. And recent time, of course, has been highlighted by rapid approval of drugs that block the PD-1 pathway for non-small cell lung cancer, kidney cancer, bladder cancer, lymphoma, and others that you can see if you look at the literature. And it's just been a very exciting time in immunotherapy to consider these checkpoint inhibitors, and also keep in mind that there are other checkpoint inhibitors that we haven't even investigated yet. Another form of immunotherapy that has been investigated over time has been that of adoptive cellular therapy. First began with nonspecific cells like lymphokine-activated killer cells given with IL-2. Then Dr. Rosenberg and his colleagues looked at tumor-infiltrating lymphocytes and showed anti-tumor effects in melanoma. And then people found that it was hard to find TILs in every kind of tumor and started cloning the T-cell receptor and putting that in patients' T-cells to see if that would work. And most recently, the technology that's proved very effective in blood-borne tumors is using a chimeric antigen receptor, which takes the antibody recognition structure, combines it with the T-cell signaling components, puts it in a patient's T-cells, and rather dramatic responses have been seen in patients with leukemia and lymphoma. And just in the last few months, there have been 2 approvals with indications in leukemia and B-cell large cell lymphomas for these CAR T-cells. And so I think it's been a long history with lots of early years with not so wonderful results, but the great results keep on coming, and they're faster and faster and create more challenges for us as we try to incorporate them into the standard therapy for our patients.
Thanks so much. That's very, very interesting in terms of the history and the recent weeks and months and years of as you mentioned, in terms of the recent approvals of the CAR T-cell therapies and the checkpoint inhibitors, many checkpoint inhibitors being improved over the past couple of years. And I was wondering if you could just maybe expand, Dr. Irva, a little bit, just a minute or two, on how do the checkpoint inhibitors work? How is it that they're stimulating the immune system, and why do they seem to work in cancer?
Well, as with most anti-cancer medications, we don't know with 100% certainty how they actually work within the patient. But we do have pretty good ideas based on preclinical and animal models for checkpoint inhibitors, and that is that these molecules are part of the normal regulatory mechanisms that hosts use to keep their immune system under control. And during the course of an immune system, as the T cells start to respond, they also gear up the machinery to turn themselves off once the immune invader has been eradicated. Now, that's fine for viral infections, but when you get into chronic things like cancer, the invader is not often eliminated and T cells get shut down prematurely. And what our immunotherapies are monoclonal antibodies that can block the negative signal that's being delivered to the T cells. And by blocking that negative signal, it allows the T cells to proliferate, make cytokines, and exhibit effector function. And we believe that is it's the releasing of T cells from negative regulation that allows them to seek out and find tumor cells and eradicate the cancer cells throughout the body.
Thank you very much. I just want to remind our listeners that we will have some Q&A after the webinar, so please feel free to enter your questions at any time using the panel on the left side of your screen. I'd like to move now to the clinic and how have these new immunotherapies influenced the clinical practice of oncology. And so, Dr. Barbie, how have you seen changes in the way you treat your patients, and how do you choose an immunotherapy versus another mode of treatment, looking at lung cancer, and then maybe over to Dr. Irva for a look at melanoma?
Sure, yeah. So as Dr. Irva described, that checkpoint inhibitors received a breakthrough of the year now several years ago, and that was because of the remarkable activity that was seen in specific cancer types. I'm going to focus myself on lung cancer just because that's my specialty. But it's clearly had activity in a number of tumor types, in particular, as we'll talk later, that tend to be on the spectrum of cancers that have a high mutational load, that are caused by, for example, in lung cancer, often caused by smoking, which causes a lot of mutations, and in melanoma by UV irradiation. And so just myself, I've started practicing as an attending lung cancer specialist since 2010, and at that time we were still predominantly using chemotherapy as well for systemic therapy, as well as radiation and surgery in selected instances. At that time, the big breakthrough in lung cancer had been so-called targeted therapy, and that is sequencing a cancer to identify specific so-called driver mutations or oncogenes. And I think lung cancer in particular, lung adenocarcinoma, is really one of the best examples of the success of that approach, where certain mutations in oncogenes known as EGFR or ALK have been associated with very dramatic activity when direct small molecule inhibitors of those oncogenes are used. But I would say the frustrating thing with targeted therapies is that while we can achieve these impressive responses, that within about a year on average, at least the first generations of these targeted therapies are associated with resistance. And so it was actually about the time when I started where the first clinical trials were initiated in lung cancer. The story in lung cancer is more about PD-1 blockade, which has shown the most degree of success. And the initial trials were starting around that time and then published shortly thereafter. I'll get to a little bit later in terms of what line we use these agents in. But as with any new therapy, the clinical trials are first employed in refractory patients, so patients who have gone through chemotherapy, and that's where we first do the clinical trials. And usually that is a very, very challenging setting in which to treat, that if they're effective therapies, they often only work for a few months. And I think what was most dramatic about these PD-1 inhibitor trials is that while the response rate, and we can get to this later, was still overall relatively low, on the order of 15 to 20% in non-small cell lung cancer, the level of activity in the responders was something we'd never seen. And so these are stage 4 patients who were refractory to therapy. In some cases, in fact, in a majority of the responders, achieving activity beyond 2 years, and so do durable clinical responses, which fit with what Dr. Irva was mentioning, that the mechanism of action what we know about is that it's reactivating the immune system and specific T cell clones to attack the tumor. And that it's much harder for a cancer to evade that kind of immune attack as opposed to one of these targeted therapies, where there can be a much greater selective pressure to escape. Now, that being said, we'll also talk later, there can be selective pressure to escape the immunotherapy. But again, where this has really revolutionized lung cancer treatment is that we are seeing these long-term durable responses that we had never seen in stage 4 patients.
Thank you, Dr. Barbie. Dr. Irva, is that similar to what you've seen in melanoma, or how does melanoma differ from what you've seen, or from what Dr. Barbie described?
In melanoma, I think that the challenges are similar. There is a mutation, a BRAF mutation, that's present in almost half of the patients with cutaneous melanoma for whom targeted therapy exists and is very effective. I think it has some of the same attributes that Dr. Barbie mentioned for lung cancer, high response rates, and perhaps not as durable, although recent data that's coming out suggests that some of these remissions are more durable than we thought. So the notion that you should always use immunotherapy first has come into question, and the notion that immunotherapy first has been based primarily on the fact of the durability of the remissions and the assumption that targeted therapy wouldn't induce durable remissions. But for melanoma, the patients fall generally into mutation positive versus wild type tumors, and if they have a wild type tumor, we go right to immunotherapy, and then the question becomes which immunotherapy. Combination therapy has been shown to have higher response rates, but it's associated with significantly greater toxicity. And certainly one of our the current problems is how to identify those patients who will either have that toxicity or identify patients who are more likely or less likely to respond, so that you can determine whether you want to use combined therapy with anti-CTLA-4 and anti-PD-1 or single agent therapy. And then we have one of the current areas of investigation is the movement from the advanced disease setting, where you're looking for improved survival and hopefully cure, to the adjuvant setting. And increasingly there is data coming out that shows that both anti-CTLA-4 and anti-PD-1 have beneficial effects in the adjuvant setting for patients with stage 3 melanoma.
Dr. Barbie, are you seeing the use of immunotherapies in lung cancer is going to move for earlier in treatment as well?
Definitely, and so whereas in melanoma, chemotherapy was never that effective because our platinum doublet chemotherapy was effective to some degree. The initial trials were all done in the second line, so after patients, as I mentioned, had been refractory to chemotherapy, and then they showed benefit when the studies were randomized compared to a second line chemotherapy. That is where the clear benefit was seen and where the FDA approvals were given to both two of the most commonly used PD-1 antibodies in lung cancer, nivolumab and pembrolizumab. The next step was to test, because of the efficacy in the second line, and as Dr. Irva mentioned, the first line efficacy in melanoma, is how would these PD-1 antibodies fare in a newly diagnosed patient with stage 4 non-small cell lung cancer. Would it be possible, which has been unprecedented in lung cancer, to actually bypass chemotherapy in favor of starting with an immunotherapy? And so there were actually two randomized clinical trials, one with pembrolizumab versus standard first-line chemotherapy, and the other with nivolumab versus standard chemotherapy. And the key difference, as we may talk a little bit later in terms of biomarkers, is that the pembrolizumab trial stratified patients. In other words, they included primarily patients with a higher likelihood to respond, and that is with a PD-L1 level in the tumor that was very high, greater than 50%. Whereas in the other trial, which compared nivolumab to chemotherapy, that strict cutoff of enriching for very high levels of PD-L1 was not performed. And so comparing these two trials, the Keynote 024 trial was the trial with pembrolizumab, the Checkmate 026 trial, the trial with nivolumab. The Keynote trial was a positive study in which the progression-free survival was significantly prolonged with pembrolizumab in the first line compared to chemotherapy, whereas in the other trial, the nivolumab trial that did not enrich, there was actually no significant difference. And for that reason, now the standard treatment of lung cancer patients involves first a diagnostic test. As I mentioned previously, we test for the targeted therapy markers, the oncogenes. Do they have an EGFR mutation or an ALK rearrangement? But also for a PD-L1 stain. And so if the PD-L1 level is greater than 50%, then our standard first-line option is treatment with pembrolizumab. To also allude to what Dr. Irva was mentioning in terms of earlier and earlier lines of therapy, there are trials both in stage 3 lung cancer, in which the cancer has spread to local lymph nodes but has not metastasized to distant locations, as well as adjuvant, so patients that have early stage lung cancers that are resected, as well as actually what's called neoadjuvant, so treating before surgery with the checkpoint inhibitor. Similar to what was just mentioned in melanoma, there was another positive trial that was just published looking at another antibody that targets the PD-L1 side of the equation, durvalumab, which showed a significant prolongation in progression-free survival in stage 3 lung cancers following standard chemotherapy and radiation. So yes, to answer your question, it is also moving earlier and earlier in lung cancer as well.
So one other question that I had, other than lung cancer and melanoma, what are there salient points to understand about the use of immunotherapies in other diseases that you're able to talk about? Dr. Irva?
Yes, every couple months seems to be another disease type that has benefit following interference with the PD-1 pathway. Clearly, patients with kidney cancer and head and neck cancer will benefit. Other diseases include bladder cancer, lymphoma, unusual tumor called Merkel cell tumor, which is a virally induced tumor. There are a number of other tumor types that either as initial therapy or more likely in the secondary setting where standard treatment has failed will benefit. And I think this just points out the value of the immune system. The immune system is looking for an antigen, and the regulation of immune responses is the same whatever kind of tumor type you have. So it's not a big surprise that if you can release the negative signals on T cells in patients with bladder cancer, that they'll respond. Triple-negative breast cancer is another disease in which it appears that the PD-1 blockers have efficacy. And another very interesting observation is the fact that since we know that tumors with high mutation burdens seem to respond more often, studies were done to look at patients in whose tumors had mismatch repair deficiencies, and these tumors, of course, have lots of mutations. And the first study was in patients with colon cancer, and indeed, if you have a mismatch repair deficiency in a colon cancer, that has a high likelihood of responding to PD-1 blockade, and in fact, other tumors that have similar genetic changes also have a high response rate, and this led to the first time ever that the FDA's approved a cancer therapy based on a genetic marker rather than the tissue from which the tumor came. So it's very, very interesting.
Dr. Barbie, would you like to add anything to that?
No, I think that Dr. Irva covered it very well. I would say one other marker in the lymphoma space, in particular Hodgkin's lymphoma, that's quite remarkable, where the malignant cell has actually been known for over a century to be this Reed-Sternberg cell that is effectively targeted by chemotherapy. But with genomic sequencing studies, it had been found that in this type of cell, that there seems to be another mechanism of activation of the pathway in which there can be genomic amplification of the locus that contains PD-L1 along with its neighbor JAK kinase, JAK2, which we'll also talk a little bit about that pathway later. But that's at least thought to in part relate to the exquisite sensitivity of lymphomas to checkpoint blockade.
To ask you about how do you know which are going to be in that 10 to 20% of patients that have the response to these drugs in terms of predictive biomarkers? What's out there? What's well validated? What's on the horizon? So, Dr. Barbie, perhaps could you talk to us a little bit about what the predictive biomarkers are that you feel are useful right now?
So I think what I was mentioning earlier in terms of the first-line treatment of non-small cell lung cancer patients, where one study was positive when enriched for a PD-L1 level of greater than 50%, whereas another study was negative when that enrichment was not performed. That does highlight the general trend in that tumors that have very high-level PD-L1 expression tend to respond better to PD-1 checkpoint inhibitors. However, this is by no means an absolute distinction, because there are tumors even with 0% expression or very low level of expression that can also respond. And that in part may relate to certain factors such as heterogeneity, that often we're only biopsying one site of a tumor and measuring PD-L1 expression in one site, and indeed there are cases in which different areas, different metastases have different varying levels of PD-L1 expression. The assays themselves, is much more complicated than a simple IHC assay, for example, for HER2, where the PD-L1 staining can be on tumor cells versus infiltrating immune cells. So that's another factor, and then another factor is sort of the dynamic nature of PD-L1 induction, that at least in vitro it is induced by interferon gamma. So there are other dynamic factors that can determine whether, when we're measuring statically in a tumor biopsy, whether PD-L1 is positive or not. It could be influenced by these dynamic factors. So I would say in lung cancer, as I mentioned earlier, PD-L1 is used as a biomarker to determine whether or not we treat with pembrolizumab versus chemotherapy in the first line. But there certainly is a need for additional biomarkers and, in fact, intensive efforts to search for these.
And as Dr. Irva mentioned earlier, with respect to colorectal cancer and microsatellite instability, the recent approval of pembrolizumab for any solid tumor that has microsatellite instability or a deficiency in the mismatch repair genes. And at N of 1, we've been starting to see a lot more diagnostic companies looking to have interpretation of those genes, of the MMR genes, of microsatellite instability, and also of tumor mutation burden, which is not yet completely validated. And Dr. Irva, I was wondering if you could talk a little bit about that. Like, where do you think the bar stands for something like tumor mutation burden and how that's established, and whether do you see that on the horizon as another companion diagnostic for an immunotherapy?
Well, I think potentially it has value. I think the concept of validation is an important one, and I'll leave that to the pathology experts. As the clinician, it makes sense, right? If you think, I think the biggest prognostic factor, or predictive factor for these tumors is whether there's T cells in the tumor. Because if there aren't any T cells for the anti-PD-1 to block the interaction with PD-L1, we're not going to see the benefits. So I think that's an important marker. We think that the mutation burden correlates with the likelihood that tumor neoantigens are being produced, and the more mutations you have, the likelihood you'd have more neoantigens, so more foreign antigens for the T cells to recognize. And while that's a numbers game, an average, it makes sense. It's clear that that's not the complete story, because while you can plot and make a graph and show that the tumors with the highest mutation burdens in general exhibit the highest response rates to anti-PD-1, you can also show within individual trials that patients who have a high mutation burden, while they have a higher response rate, there are clearly many patients who don't respond. And the reverse is true, that you can have a low mutation burden in your tumor and you can respond to therapy. Whether that's just sort of a random statement upon whether a neoantigen was formed or not, we don't know. But I don't know. It clearly at this time is not a reliable enough test that I would use to give a thumbs up or a thumbs down. It might be an extra piece of information one might use to decide on how to treat the patient.
I'll just add to that, in non-small cell lung cancer, I would say perhaps the similar evidence that there is a trend, if you have a higher tumor mutation burden, to respond, was in the negative first-line trial, the Checkmate 026 trial, where I mentioned there was no enrichment for high PL1 levels. They actually did a retrospective analysis and actually segregated patients based on tumor mutation burden. And when they did focus specifically on those non-small cell lung cancers with a high tumor mutation burden, which they defined as greater than 243 mutations, in that subgroup, there was a similar progression-free survival benefit to the Keynote study. It was approximately 6 months up to a 10-month difference. However, that was not a pre-specified analysis. And again, so as Dr. Irva mentioned, further work is needed in this sort of intermediate zone outside of mismatch repair deficiency, how to incorporate this into clinical practice.
And do you see anything else on the horizon that's out there in terms of what other predictive biomarkers there might be, perhaps looking at the tumor microenvironment or other pathways that you think might be able to, that there's some research on predicting response to immunotherapies?
Yes, so I do think that, as I mentioned, tumors that have a plethora of tumor-infiltrating lymphocytes appear to do better even without treatment, and certainly appear to respond better to the immunotherapies that we have available, indicating that something about an immune response ongoing in the tumor is beneficial. However, as your question suggests, the tumor microenvironment is a complicated one with not only the immune cells infiltrating, but tumor cells and then normal host stromal cells, which are known to make a variety of factors that can perhaps exclude T cells from the environment, that can make cytokines or chemokines that attract T regulatory cells or myeloid suppressor cells. And I think that all those things sound like processes that you can interfere with, perhaps in a therapeutic way, but first we need to understand them. And I think what's going on now that we'll see results from in the long run are extensive studies of the tumor microenvironment, both with a genomic approach and a multispectral imaging approach to look at what cells are there, where are they, how do they exist in relation to each other, and how does that affect the outcome. I mean, a very I would say, primitive's not a kind word, but I think it's a primitive attempt to do that is the immune score, which has been published for colorectal cancer and actually gives quite important prognostic information for patients with colon cancer, and people are studying that in other tumor types. I think by increasing the number of patients who are sequenced before therapy, at least in melanoma, we are finding clues as to what may be responsible for PD-1 or resistance to anti-PD-1 therapy, primary resistance, and those things are that there are a small percentage of JAK1 and JAK2 mutations. There can already be loss of MHC restricting elements like beta-2 microglobulin that would make it very suspicious that this tumor wouldn't respond to therapy. And I think while those things are experimental now, those will be things that we use when they become part of our standard measurements and we've accumulated enough patients and experience to understand what their mutation or absence means.
You just brought us right into the next topic that I wanted to ask about, which was resistance. And I wondered, Dr. Barbie, if you have anything to add about molecules that you see as potentially on either now or in the future as helping us understand which patients wouldn't respond.
Yeah, so I think that sort of our bias in terms of studying response and resistance from the targeted therapy space is to focus on cancer genomics. But yet, with immunotherapy, it's very clear that there are so many other factors beyond specific mutations that could influence response or resistance in terms of the neoantigen landscape, in terms of is the neoantigen in a driver mutation. There have been studies looking at the clonality of the neoantigen. And so I think, in terms of specific mutations and specific pathways, as Dr. Irva mentioned, the JAK pathway is emerging as a very clear, at least in preclinical studies, marker of response or resistance in that in exceptional responder patients, such as the PD-L1 JAK2 amplicon that I mentioned, or also there have been mutations identified, activating mutations in JAK3 that in selected cases have been associated with long-term response. So that activation of the pathway and signaling through the pathway is associated with improved immune response, whereas conversely, loss of function mutations in the JAK pathway have been found with acquired resistance. And so, but I do think that in terms of acquired resistance or innate resistance, there are also other models that have emerged in that while there's clearly a subset of tumors that are destined to respond, that the large majority, at least in lung cancer, which is more than around 80% of patients that do not respond, there's certain categorizations that we have started to form in terms of reasons for intrinsic resistance, and I think two Two of these sort of more general categories are what one has been termed immunologically cold tumors, so that there are very few T cells present at baseline. And so one way to try to tackle this is to increase the antigenicity of these tumors and to try to prime immune responses. But I think another very important bucket are tumors that are primed to that could respond immunologically, but actually their immune response is so-called dysfunctional, and that is, instead of recruiting a T cell, a CD8 T cell that's expanded and hitting a target neoantigen, that the immune microenvironment is such that certain cytokines and chemokines favor the recruitment of myeloid cells, myeloid suppressor cells. Also, there's another immune suppressive cell, Tregs, such that there is an immunologic response, but it's a dysfunctional response that creates a suppressive environment. And how much that is dictated by genomics remains to be seen. And thus, one other thing that I wanted to mention is this, in terms of this dynamic assessment of tumor response, that nearly all current approaches to study response and resistance are done in one measurement. So there have been some studies that have performed repeat biopsies of patients pre and post checkpoint blockade, and it turns out that the dynamic response can actually provide you even more information in terms of how an immune response is headed.
Thank you. And then one other question I had, at N of 1, a lot of the cases we see have both, an MSI result, say an MSI high, and then maybe, various targeted possibilities in terms of mutations that would suggest a targeted therapy. How do you balance those? If you had a high, an ERBB2 mutation in lung cancer and high tumor mutation burden or high MSI, how do you approach that in terms of choosing or combining? What's the role of combined immunotherapy with targeted therapy? I wonder if you could comment on that.
Yes, I think the best example, in terms of lung cancer, just since you were mentioning lung cancer, I think the best defined is the EGFR mutant lung cancer, which tends to occur in never smokers. So at least in that instance, there tends to be a relatively low mutation burden. As I mentioned, there are effective targeted therapies, but actually the response to checkpoint blockade, even in resistant refractory EGFR mutant patients, has been exceedingly low, so significantly lower than the general non-small cell lung cancer population. And so, and similarly with ALK, where the jury is still out and there can actually still be high PD-L1 expression, the general consensus that's emerging is that in terms of the never smoker targeted therapy patients, that targeted therapy is at least the first line option for these patients, whereas in the PD-L1 greater than 50%, that's where we now bin patients to treat with first-line pembrolizumab. But as you mentioned, it's much more complicated, and so I think it's, one good example is KRAS, for example, which tends to occur in smokers, and there seems to be certain genomic modifiers with oncogenic KRAS that dictate response or resistance, and for example, mutational load may be why some KRAS patients respond, others don't. There was another study looking at oncogenic KRAS as a neoantigen. It's very clear, because KRAS is a driver mutation, that if one can develop an effective T cell specific for KRAS, that's much more likely to eradicate the entire tumor, although that antigen, still there could be resistance that could replace KRAS signaling, and that antigen could drop out. And then finally, there are other genomic modifiers within KRAS, these tumor suppressors, P53 and LKB1, that seem to dictate response. So I think for these kind of subgroups, it's going to take many more years of larger data sets of response and resistance to really know the statistics. But I would say the EGFR is probably the best example in which we believe that there's intrinsic resistance.
Dr. Irva, would you like to add anything to that from your experience in melanoma?
Well, that was a great explanation. But in melanoma patients, since we have targeted therapy and immunotherapy, just like lung cancer, and they appear to have no non-overlapping side effects, mechanisms of action. One would think the resistance mechanisms that develop will be different. It's sort of been everyone's idea to try and combine them as soon as the agents were available. First attempts were associated with significant and substantial liver toxicity, so I think enthusiasm waned. However, over time, now that we treat melanoma with combined BRAF and MEK inhibitors, we can actually see that in some patients who've had biopsied, there are positive immunological changes that occur as a result of inhibition of the MAP kinase pathway. And that makes it even more appealing to combine targeted therapy with our immune agents. And while there are a number of studies ongoing attempting to determine dose and schedule and make sure it's safe and determine efficacy, those results are still pending at this time.
Thank you both so much for that analysis. And then just to conclude, I'd like to ask you each to talk briefly about what do you see on the horizon? What's next for immunotherapy beyond checkpoint inhibitors, beyond the CAR T-cell therapies that have been developed? Dr. Irva, would you like to start?
Well, sure. I think that I don't know that we're totally beyond checkpoint inhibitors yet, because as we talked about before, there are other checkpoints yet to be investigated VISTA, TIM3, TIGIT, there are adenosine receptor, there are a number of other approaches that could add value, and some of the ways that tumors may become resistant to one checkpoint inhibitor is to upregulate a different one. The other thing that is currently an active area of focus, and I think will find its way to the clinic eventually, is there are not only checkpoint inhibitors, there are actually co-stimulators that turn T cells on or make them more active. And OX40 and 41BB and GITR, these are approaches that make T cells more effective. And so I think we will see the agonists make their way. They're in the clinic right now. And in fact, I think we'll see combinations of agonists and checkpoint inhibitors as ways that we treat cancer in the future.
Dr. Barbie, would you like to add anything to that?
Sure. Yeah, I think the main lesson that I think I've learned throughout my short career in terms of identifying effective therapies and how to improve is that personalization is very important. So, for example, for the EGFR targeted therapy in lung cancer, it was first applied without knowing that EGFR mutations predicted response, and actually the early trials were negative based on that. The next marker I just mentioned, PD-L1, was very instrumental, despite it not being a great biomarker, but that the study that stratified for high levels and sort of tipped the deck in favor of a response that was positive in the first line, whereas when that biomarker wasn't used, the study was negative. So I think with these combinations that are being developed, whether it's two different checkpoint antibodies, whether it's a checkpoint antibody plus a small molecule, that we need smarter ways in which to identify which patients are likely to respond to which combination. Because it's likely that every patient is going to have a unique mechanism of intrinsic resistance. So the sooner we can figure out how to identify which combination might work for which patient and then stratify clinical trials based upon that, I think there's a much greater likelihood of identifying successful combinations that are personalized.
Well, I'd like to thank you both for your time and for the perfect discussion that we had today, and remind the audience again that we are, our speakers are happy to take your questions. So thank you for listening.
Thank you, Drs. Elkin, Barbie, and Irva, on an enlightening and comprehensive discussion on immuno-oncology. For attendees, this is your last chance to submit a question for today's speakers. Simply type your question in the box to the left and submit. Reminder that today's webinar will be available on demand in 72 hours should you want to listen again or share it with a colleague. Thank you all for attending today. We will take a slight pause and then be back with your questions.
So we do have a couple of questions that we're happy to address today. The first question that I would like to pose to our speakers is a question about testing methodology. Liquid biopsy has been growing as a diagnostic for solid tumors for sequencing for NGS. Do you have a sense of its use for predicting sensitivity to immunotherapy? Is it sensitive enough? Do you think the thresholds will be the same?
As a melanoma doctor, I understand the potential value of liquid biopsies for assessing use of targeted agents. I think in terms of what we do in the immuno-oncology space right now, that I'd have to consider it an area of investigation. If you think about the marker that people look at most often, the expression of PD-L1, it's difficult enough to assess when you have tumor tissue in your hand and you're looking at it under the microscope. PD-L1 expression doesn't correlate completely with responses in melanoma, has, I think, a greater role in patients with non-small cell lung cancer. But if you think of what happens at the tumor site, PD-L1 positive cells can be immune cells, PD-L1 positive cells can be tumor cells, they can be different in different tumor sites, and if all of those shed DNA and the DNA is then collected in the serum, it's really hard to know what that means for each given tumor site and how it will respond to immuno-oncology. So I think an area of interesting research, but not something we could think about clinically yet.
This is Dr. Barbie. I completely agree. Definitely an area of investigation. I think the one thing to add could be that in terms of assessing mutational load and mutational spectrum, as these panels become broader, and the technology to do broad NGS and plasma becomes more sensitive, that tracking that over time might be another way in which one can look at how the landscape changes over time in circulating plasma. But I agree that especially looking at PD-L1 in plasma, it's sort of a really preliminary effort at this point.
Thank you so much. Turning to some other areas that we didn't necessarily talk about, what do you know about the use of immunotherapies in glioblastoma, whether checkpoint inhibitors or other types of approaches? Are you aware of anything that looks promising at this point? Maybe Dr. Barbie?
Yeah, I would say that everything still remains in the clinical trial phase in glioblastoma. There haven't yet been any FDA approvals for PD-1 blockade or CTLA-4 blockade or other approaches, but there's definitely exciting vignettes of responses with these and other vaccine-based and other immune targeting approaches in glioblastoma, but nothing yet approved.
And then a couple of specific questions in terms of non-small cell lung cancer. One question is, are the therapies that are available for non-small cell lung cancer also available for neuroendocrine lung tumors?
Yeah, so this is also a very intense area of investigation in small cell lung cancer, which is a highly aggressive neuroendocrine variant that's occurs about 10% of the time in terms of aggressive lung cancers. Both pembrolizumab and nivolumab have demonstrated single-agent activity in the treatment-refractory setting. And then there's also evidence comparing nivolumab with in the refractory setting that there appears to be higher activity with the combination. That being said, these are small numbers of patients in a refractory setting. They have not yet been given a label. However, they have made it into the NCCN guidelines. I think the answer will whether or not the efficacy versus the added toxicity of the combination, that will be forthcoming soon, as there was a randomized trial in small cell lung cancer in the maintenance phase. So after initial chemotherapy, the standard of care has been observation, that randomized comparison of observation alone versus single-agent nivolumab versus the combination, and hopefully that will answer the question there. For lower grade neuroendocrine tumors such as lung carcinoid, the jury is still out. Unfortunately, it's a rare tumor type, but there's definitely clinical trial efforts to look at activity in that population as well.
Thank you. And then moving to some of the other immunotherapy approaches beyond checkpoint inhibitors, what can you tell us about natural killer cell approaches? Dr. Irva?
Well, natural killer cells have been identified as a potentially useful therapy in cancer for a lot of years. They recognize tumor cells in a different way than T cells do. We've had activators of NK cells around for many years. Interleukin-2 is a very potent activator of NK cells. In fact, early on, people used interleukin-2 to grow NK cells in the laboratory and then adoptively transfer them before studies such as the tumor-infiltrating lymphocytes where you grow specific T cells. What those therapies had in common were occasional responses, some tumor regressions, but nothing significant enough in a way that would lead to approval of an NK cell therapy. However, we've learned a lot more about how these cells work, and if you look in the literature, you'll see lots of different studies being done. Again, some with adoptive transfer of NK cell, looking after bone marrow transplantation. We now know that NK cells have these inhibitory receptors on the surface, and companies are making antibodies which interfere with these inhibitory receptors, leading to enhanced tumor regression, and those things are being looked at alone and show some promise in combination with other agents like checkpoint inhibitors. So NK story's not over. Stay tuned.
Thank you. And then one final question today. Even just yesterday, I think there was a recent approval of another CAR T cell approach, and we didn't get a chance to dwell too much on the CAR T cells today. But I was wondering if you could speak a little bit about that approach. Most of the approvals so far have been in hematologic disorders and lymphomas. Do you think that CAR T cells will be extensible to other diseases, and where do you see the future going in terms of CAR T cells?
This is Dr. Irva again. I think it's a very exciting area. CAR T cells, of course, are the chimeric antigen receptor modified T cells, and they use the immunoglobulin binding region coupled with the T cell signaling region to redirect the power of T cell killing to any antigen that can be recognized on the surface of a cell. And so the antigen that's being targeted is key, and CD19, which is found on normal B cells and malignant B cells, has proved to be a very useful target, and this therapy has been approved now for relapsed childhood ALL and recently, as you mentioned, in relapsed adult large B-cell lymphoma. It's a reasonably toxic therapy, requires some real experience in managing the side effects. A disadvantage of the approach is that it can't recognize antigens that aren't on the surface of the cell, which probably represent the majority of neoantigens that we think the T cells that we're making and the checkpoint inhibitors are causing to be recognized. the value in the B-cell lymphomas is that the lack of normal CD19 positive cells, at least transiently, doesn't seem to have a big effect on the patient. The challenge in solid tumors, and see what Dr. Barbie thinks about this, is in identifying a target that's safe, one that is present only on the tumor and not shared by other normal cells, the recognition of which could lead to toxicity and has indeed led to toxicity in some of the early phase studies. So I think there are strategies being developed around that, making combined CAR T cells with inhibitory receptors and activating receptors, but that's still an open question as to how useful it will be in other solid tumors. Dr. Barbie, what do you think?
I completely agree that the advantage of the B-cell leukemia and lymphoma target is that there's a specific cell surface marker, CD19, it turns out to be an excellent target. Whereas in solid cancers, while there are some shared antigens, they're not always even linked as intimately to the driver potential of the tumor. So while there have been some approaches at certain antigens such as mesothelin, that nothing thus far has been successful. And so whether there will be a stereotypic antigen for specific solid tumors or more likely personalized sequencing of T cells to try to identify T cell clones that are recognizing effective tumor neoantigens but are unable to expand, that it perhaps identifying that in a personalized manner for patients and then developing CAR T cell therapy might be one successful route for solid tumors. One other sort of vignette, kind of harkening back to the glioblastoma question, Dr. Marcella Mouse's lab at MGH published a Science Translational Medicine paper looking at one of the EGFR mutants that's very commonly found in glioblastoma that does not sensitize to EGFR inhibition but does create a specific antigen. And they showed very nicely in a preclinical model and then in patients infusing CAR T cells directed against that antigen, that while they could, in fact, see trafficking into the tumor, what they also found was upregulation of Tregs. So it's also very likely that there are immunosuppressive components in the microenvironment that limit the efficacy of CAR T cells in solid tumors that are sort of different from a liquid-based microenvironment.
I want to say thank you very much to our speakers today, to Dr. Dave Barbie and Dr. Walter Irva, and thank you to all of you for listening today.
Thank you.
Great, thank you. And with that, we've come to the end of our webinar. I want to remind everyone that the webinar will be archived on our site at clinicalomics.com for 6 months. So if you missed parts of it, you can watch it again, or feel free to forward the link to your friends and colleagues, which we always recommend. I'd like to thank Cheryl again for moderating the panel, and David and Walter for their informative discussions. And I'd like to thank the audience for their attention and very thoughtful questions. And a very special thanks to N of 1 for sponsoring this webinar. So hopefully we'll see you again at another Clinical Omics webinar in the near future. Goodbye for now, and happy Halloween.